Assalamu alaikum. Today our topic is oral ulcer. So first of all, you must know what ulcer is. Ulcer is actually breach, break, or discontinuity of the skin, epithelium, mucous membrane. Anything among this is called an ulcer. So such kind of lesion in oral cavity is just called an oral ulcer. So the oral cavity, for this you must know by your anatomy that what are the boundaries and what are the contents of the oral cavity. So the oral cavity, it is defined as a region and it starts from the skin mammalian junction of the lips and back posteriorly up to the free border of the soft palate. This is superiorly. And inferiorly, it ends up posteriorly to the line of circumambulate papillae inferiorly on the tongue. Laterally, the oral cavity ends at the interior palatoglossal pillar. These are the boundaries interiorly, superiorly, posteriorly, and laterally of the oral cavity. And among the contents of the oral cavity are, these are the lips, buccal mucosa, upper and lower alveolar ridges, with their attached gingiva and the retromolar tribune. This is the region which is behind the last molar tooth. The hard palate and the floor of the mouth and the anterior 2/3 of the tongue. Tongue is not all the tongue is included in the oral cavity, only the interior 2/3 of the tongue. So any lesion in this region, which I have discussed with you, the subsets of these contents of the region, any lesion in this area comes under the topic or under the heading of oral cavity. And ulcers in this region will be called as an oral ulcer. So, infection of the oral cavity, it may be as an isolated to the head and neck region, or it may be viral in origin, or it may be as a part of that is infectious, some infectious conditions, diseases, or it may be as a part of systemic diseases. That means that the disease is a systemic involving other organs, other part of the body, but along with some lesions in the oral cavity, some type of lesion in the oral cavity. So we'll discuss it one by one. So coming to the viral infections, toxic A virus, this is the virus, toxic A, B virus, both are involved in the oral cavity or offense, but mostly the viral infection, toxic A virus, is involved in the viral infections of the oral cavity. Herpes simplex is another one, but it presents in one or two ways or one or two types. Primary herpetic gingivostomatitis and secondary herpetic. In primary herpetic, there is some difference among this. In primary herpetic condition, gingivostomatitis, there is a painful erythematous oral vesicles, and these vesicles usually rupture within 24 or 48 hours, but usually within the 24 hours. Sometimes they causes or leaving a coalescent ulceration that is combined the different small vesicles, many small multiple vesicles. These ruptures form a combined large ulceration. So the secondary herpetic infection, in this condition, the virus remains dominant in the patient neuronal ganglia for life, and they may be there for life without causing any infection or to the patient, but sometimes it may be activated and cause an infection. And when it causes the infection, the secondary herpetic infection, when it causes infection, it is consisting of a burning sensation and again the vesicular eruption in the oral cavity. So there are two types, primary and secondary. In the primary, it is painful erythematous, oral vesicles may resolve or rupture within 24 hours and leaving a large ulcer, coalescence, ulceration. And secondary, it remains dominant in somewhere in the neuronal ganglia. And when it is activated, it causes a vesicular eruption in the oral cavity. These are the two types. Next, the diagnoses are usually by a viral studies or biopsy. And the another condition is herpes labialis. And the herpes labialis, when these herpes involve the lips, it is called the herpes labialis. Right? The treatment is usually symptomatic with a spontaneous resolution. It occurs usually within 2 weeks. Sometimes, or in some studies, it is recommended that antiviral therapy may be needed. Measles, as you know, rubella. This is another viral condition, viral diseases, in which specifically complex spots develop. And these complex spots, actually, these are when the virus, these are produced by the virus with a red rash spots, and with central bluish white specks in the buccal mucosa. These and such signs are seen in a patient buccal mucosa. These are the special types of the rubella or measles. That these are a rash of red spots with central bluish white specks, specifically on the buccal mucosa. Cytomegalovirus also infects usually the immunocompromised patient, and infections are characterized by large mucosal ulcer. The cytomegalovirus immunocompromised patient, as you know, these are either diabetic or HIV patient or patient on radiotherapy or steroid therapy. All such patients, when the patient has such status, then we label it as immunocompromised. Right, fungal infection. Fungal infection is one of the most common infection of the oral cavity, and it is usually also called as an oral thrush. You may have come across this term. The Candida albicans is an opportunistic microorganism. Here, the opportunistic means that in the virus which take some advantage of a patient, in which patients, in patients which are immunocompromised or the patient is on long-term antibiotics. How? Like this. Actually, the Candida albicans is a part of normal oral flora. Right? These are present in the oral flora normally. And when the host immunity is decreased, how it is decreased? It is decreased either the patient is diabetic or immunocompromised, as I have discussed earlier, or the patient is receiving or received radiotherapy, or the patient is having on a steroid therapy. These patients are immunocompromised. And then what happens? Or the other condition, when the patient is on a long-term antibiotics, that is antibacterial therapy. So these conditions causes the normal flora of these Candida albicans, causes these to overgrow in the growth and the concentration. You can say that it get increased and causes lethal effect on the patient oral cavity and causes infection. So in a normal flora, in a normal concentration, it is not lethal or dangerous to the patient. But when there are some condition that causes the Candida albicans to overgrow, then that causes infection. So this is opportunistic microorganism. Right? It is characterized by dry, painful. The ulcer is usually dry, painful, with white plaques and covering the tongue, hard palate, oral buccal mucosa. These are the subtypes. I have told you when these regions are, any of these regions are involved, so we can say that the oral cavity is involved. So in this, usually the tongue, hard palate, and buccal mucosa involved. How? It is a dry, painful, and with a white plaque you can see over these regions. For diagnosis, we usually fungal culture is needed for a definitive diagnosis. Acute atrophic candidiasis, it is also a fungal infection. In which the mucosa is ulcerated, and ulcerated mucosa is a characteristic appearance in such. Angular cheilitis. Angular cheilitis, it is a condition with a painful fissure. Fissure means cracks, longitudinal cracks, horizontal cracks. These are called fissures. Where at the oral commissure, and you must know by your anatomy that what is oral commissure. Other fungal agents that can involve the oral cavity include histoplasmosis, mucormycosis, and these typically affects the hard palate. You have seen that different infections, viral, fungal, they have typical sites to be involved. Other lesions of the oral cavity often presenting with inflaming systemic disorders. It means that the other body system is involved with symptoms, signs, symptoms, and involvement of the oral cavity in a form of ulceration. So systemic inflammation disease most commonly affect adults, but may occur in children and adolescents. Any age group can be involved in systemic disease. Kawasaki disease is one of the acute onset with idiopathic multi-system vasculitis. Vessels are affected in this Kawasaki disease, and it usually occurs in children, and in which group? Under the age of 5 years. Strawberry tongue, fissures, lips, as I have told you what fissure is, mucosal erythema, and necrotic pharyngitis. Here the pharyngitis is also known. And if it is in the children, this condition, this disease in the children, and if untreated, so it can develop cardiac complication. But what is it involved systemically? Which areas? Vessels. And the treatment consists usually of the gamma globulin spray. Wagner's granuloma. Wagner's granuloma also affects the oral cavity. Which area? The gingival hyperplasia is common, and it is a painful mucosal ulceration. Ulceration is there in the oral cavity with which area? Gingival area, and the ulceration is severely painful. And these ulcerations are surrounded by erythematous margins. Ulceration with margins which are erythematous. And next is the Becher syndrome, is a systemic inflammatory disorder, and it is characterized by recurrent ulcer. Recurrent ulcer means that it is repeatedly, ulceration occurs repeatedly. But here, the system which is involved specifically, that is ocular, that is ophthalmic, eyes ophthalmic regions are involved, in which the ocular inflammation, such as uveitis, iriditis, iridocyclitis, and these somewhat helps in the diagnosis. We see such characteristic in the oral cavity along with ophthalmic changes, ophthalmic diseases, then we can say that yes, it is a Becher syndrome. Here the corticosteroids and chlorpromazine and kylovir, that is the antiviral, have been used for the treatment. Bitter syndrome. This is also a systemic disease in which the urethritis, uveitis, conjunctivitis. Here, the arthritis is a additional. Ophthalmic and you can say that the joints are involved. Here, the ulceration is superficial erythematous with white rim. In the previous, it was the Wagner's. It has a erythematous margins or rim, and here the rims are white. That the margins are white. So these are the differentiating points of different ulcer in the oral cavity. How to differentiate? How to give your differential diagnosis? SLE or systemic lupus erythematosus. These are oral cavity manifestation including xerostomia, petechia, hemorrhagic bullae, and white mucosal keratosis. These are the conditions. This is also systemic. Aphthous stomatitis and recurrent aphthous ulcer. It usually involves female. Females are most commonly involved in this. And before these ulcers appear, 48 hours of prodrome, dysesthesia, and erythema for the mucosa. These are the prior symptoms before actual appearance of ulcer. In aphthous ulcer, there are three categories: minor aphthous, major aphthous ulcer, and herpetiform ulcer. Minor aphthous ulcer, there are differentiating points. Listen to it clearly. Minor aphthous ulcer, these are a shallow, painful ulcer in the oral mucosa. And this, here the oral mucosa is covered by a gray membrane. It specifically affects most commonly the buccal mucosa, lip, and tongue. It resolves sometimes, it resolves spontaneously within 2 weeks. But it may reoccur at regular intervals. After spontaneously resolution, it can or it may reoccur regularly at intervals. These are the specific features of minor aphthous ulcer. But the major aphthous ulcer, here the ulcer is again painful, but the size in this ulcer is usually greater than 0.6 centimeter. And which areas it involves? It involves the soft palate, floor of mouth, and sometimes the peritonsillar mucosa. Here it persists up to 6 weeks. And it again can reoccur at regular intervals. So you have seen the difference between the minor and major aphthous ulcer. Next one is the herpetiform ulceration. Herpetiform ulceration, it is less common as compared to the above two, but multiple painful. Here the ulceration or lesions are pinpoint as compared to the other two. These are small and pinpoint, and it merges of ulcines to form a large irregular ulceration, and it can occur in anywhere in the oral cavity. So the minor one is shallow, the major one greater than 0.6 centimeter, 0.6 centimeter, and the herpetiform ulceration are pinpoint, and when these merge, it can form a large ulceration, and the sites it can occur anywhere in the oral cavity. Now, the lichen planus, it is a common immune-mediated inflammatory disorders of the epithelial surface of the skin and the mucous membrane. It's usually considered as a disease of adulthood and may be part of systemic disease. This lichen planus of the oral cavity is usually found on the tongue, buccal mucosa, and gingival margins. The reticular type here is more common and appears as isolated or coalescent white papules, or known as Wickham stria. This also is a symmetrical, usually asymptomatic. So these have different features and differentiation between the planus and reticular type. The another one is erosive type that contain ulcerative centers with lines of papules at the periphery, and it has the tendency to undergo malignant transformation. So such type of ulceration are somewhat need special concentration because they have the chances to undergo malignant transformation. So biopsy of the periphery of the lesion provide a diagnosis. We take a biopsy to diagnose or confirm that whether it is a erosive type or not. Symptomatic symptomatic lesions may be treated with topical, injectable, or corticosteroids. Corticosteroids, where the terms come, corticosteroids mean that we give steroids, injectable or systemic. The autoimmune disorders also causes ulceration in the oral cavity, and amongst the pemphigus vulgaris, pemphigoid, and cicatricales pemphigoid affects the adult tissue. And autoimmune disease that in which these conditions may be distinguished from the clinical and histological, because different types of autoimmune diseases, different types of the above conditions of the oral cavity, this can be differentiated only on the clinical, that is clinical examination, history, and histological investigations and immunocharacteristics. All demonstrate a loss of cohesions among the epidermal cells that results in accumulation of intradermal fluid. Cohesions mean adhesions, attachment. In all the above, there is a loss of cohesion. That means there is that the attachment of the epidermal to the underlying structure is detached, and what happens? Fluid accumulates in between these spaces, and later on the blisters appears. In pemphigus vulgaris, the loss of cohesion occurs in the epidermal layer, and in pemphigoid occurs in the basement membrane. This is the difference. Nikolsky sign, it is a loss of epidermis by rubbing skin or mucous membrane. This is the sign. Occurs in the pemphigus vulgaris. So most cases of pemphigus vulgaris occurs in children and begin in the oral cavity. Vesicles, villi form and rupture, leaving a painful ulceration in this condition. The oropharyngeal portion of the upper aerodigestive tract is lined primarily with the stratified squamous cell epithelium. This is most commonly non-keratinized, but it can become keratinized in response to irritation, any disease or such condition that can cause an irritation in these non-keratinized can become keratinized in response to irritation. That may be of a different type. So the most common malignancy of the oropharyngeal structure is squamous cell carcinoma. Squamous cell carcinoma is the most common, and it occurs in a frequency. The frequency is high. So these lesions are more commonly keratinizing, but non-keratinizing one can also. Usually when we see a squamous cell carcinoma, it is for the most of the time we see it is a keratinizing, but rarely non-keratinizing can also occur. Euplakia and erythroplakia. The erythroplakia and erythroplakia are also the common one and common in the oral cavity. These lesions undergo malignant transformation. These have the importance in this sense that malignant transformation occurs in such conditions when seen in the oral cavity. So it is a sign. And usually, which sort of squamous cell carcinoma? With this occurrence are more commonly in the erythroplakia lesion. That is leukoplakia and erythroplakia both. But in the leukoplakia, in the erythroplakia, the malignant transformation or chances of squamous cell carcinoma are more as compared to the leukoplakia. These are most commonly associated with. Then the tobacco and alcohol exposure. These act as a carcinogen. Carcinogens means that these two, tobacco, alcohol, when a person is using tobacco separately or alcohol separately, these both are carcinogens that can cause cancer in the oral cavity. But when both are combined or used combined, then there are a greater risk of developing cancers. Betel leaves and areca nut, that is palm in our regions which is usually the common used in Pakistan and India, especially in Sindh, Karachi. We may have seen these causes the oral cancer and the oral squamous cell carcinoma. It is the most common, and in Karachi it is very common because of the vast extensive use of the betel nuts, leaves, and this areca nuts. Viral infection have also been shown to be associated with the squamous cell carcinoma. This coming back to the betel leaves and areca nuts, it can cause any part of the oral cavity, tongue, buccal mucosa, gingiva, palate. It can have any area of the oral cavity. Right. Oral viral infections also have been shown to be associated with squamous cell carcinoma. These has been studies. The viral have been studies viruses that they have also association with squamous cell carcinoma. Squamous cell carcinoma of the oropharynx present with a variety of symptoms depending on subtypes of the primary neuroplasm. Now, the squamous cell carcinoma of the soft palate symptoms are pain. Generally, the symptoms are pain. Odynophagia means swallowing, painful swallowing, you can say. And they can extend along the soft palate up to the tonsil structure, retromolar trigone, or anteriorly along the hard palate. So I've told you that it can involve any area, any region of the oral cavity, and it extends back to the oropharynx. So morphologically, squamous cell carcinoma can be classified according to their growth pattern. And what are the growth pattern? Three types of growth pattern are seen in the squamous cell carcinoma: either exophytic, infiltrative, or ulcerative. These are the three main morphological conditions of the squamous cell carcinoma. Okay, thanks.